Welcome everyone to the mini lesson and practice questions on anxiety. I am ChicagoDLSinc. I offer one-on-one and group sessions, tutoring for Naplex and MPJE. If you have any questions, feel free to send me a DM. And shout out to Suspicious Bunch and Pharma Turtles for setting this up. The resources I use are RxPrep and Pass Naplex Now. Both are excellent resources. Whichever one you decide to use, make sure you do it fully. And if you feel like you're doing practice questions and something is lacking, make sure that you fill in the gaps there. Please hold your questions until the end, and everyone's name looks familiar. I'd be happy to answer any questions or concerns that you have. If you have already attended this, I did beef up the presentation. There should be more information and more questions. So let's go ahead and get started. So anxiety can be primary or secondary. Primary being there's no medical or uh, external cause for it. And then secondary, of course, will be in relation to another condition or caused by other medications. We have fear, worry, along with physical symptoms, which can be tachycardia, palpitation, shortness of breath, GI upset, chest pain, insomnia, and fatigue. Now, some of the types of anxiety disorders, we're going to have GAD, which is generalized anxiety disorder, SAD, which is social anxiety disorder, and not to be confused with SAD, which is seasonal affective disorder or seasonal uh, affective depression. Then OCD, which is obsessive compulsive disorder, post traumatic stress disorder, panic disorder, as well as specific phobias. There are certain lifestyle changes that you can do to help reduce stress or provide healthy mechanisms for coping. That can be increased physical activity, volunteering, or community work, yoga, meditation, and CBT. CBT is cognitive behavioral therapy, and that is for a lot of psych conditions is first line for non-pharmacologic treatment. St. John's wort is very high yield. It is a strong CYP3A4 inducer, and it can cause photosensitivity, and it is serotonergic. There is no study yet that shows that quantifies the effects that St. John's wort has. So, however, it is high yield in testing and available over the counter, and many people choose to take it without being aware of the myriad of drug interactions. Valerian and valerian root is used for anxiety and sleep. However, it can be contaminated with liver toxins. Kava is a relaxant but can cause severe liver damage as well. Next, we have a list of drugs that cause anxiety and albuterol, antipsychotics, bupropion, caffeine in high doses. There's actually a condition called caffeine-induced anxiety. Remember that you're feeling anxious, and then you not take, you drink coffee, and who doesn't like coffee? I know I'm a big fan, and it can exacerbate existing anxiety. Uh, and I have felt that before. Decongestants, illicit substances, levothyroxine in a therapeutic overdose, steroids, definitely stimulants, as well as theophylline. All right. Can anyone in the chat tell me a brand name for haloperidol? Once again, in the chat, please type the brand name for haloperidol. And if you're just joining, welcome to Anxiety 2. All right. Next, we have diagnostic criteria. And if you answered Haldol, that is correct. Very good. The diagnostic criteria for generalized anxiety disorder is going to be excessive anxiety occurring on more days than not for at least 6 months. And also, there's going to be an association with three of the following symptoms: restlessness, easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. There's going to be significant distress or impairment in daily life functions. And this is not due to a substance or a medical condition. So remember, the patient is just anxious. That is how their brain neurochemistry works. So next we'll talk about different medications. The biggest class here is going to be benzodiazepines, aka benzos, and they enhance the inhibitory effect of GABA by increasing neuronal membrane permeability to chloride ions, resulting in hyperpolarization. That is the mechanism of action that is important. The duration of action varies as a function of the active metabolites. So you have long acting, which can be 24 to 100 hours, and we avoid these in the elderly. Intermediate acting is going to be 12 to 24 hours, and such as lorazepam, and this is useful in the elderly, and lorazepam does not have an active metabolite. Short acting is going to be triazolam, has a half-life of 1 to 6 hours, and may lead to rebound anxiety. Now, I've only chosen one example for each. There are several. Interactions are going to be 3A4 inhibitors, 3A4 inducers, as well as hepatic, those that are substrates. Antidote is going to be flumazenil IV administered over 30 seconds. Now, if you're new, these presentations are not comprehensive. They're supposed to be mini lessons. So if I don't cover something or if you notice something that is important, please make sure that you review that. Now, benzodiazepines are controlled substances Schedule 4. Can anyone tell me a Schedule 2 substance? Put it into the chat. Schedule 2. All right. So, well, give everyone a chance to answer. Short half-life is going to be alprazolam, oxazepam, triazolam, and midazolam. Medium is going to be lorazepam, temazepam, and estazolam. Long half-life is going to be chlordiazepoxide, clonazepam, diazepam, and flurazepam. Very, very good. So in the chat, I have hydrocodone and morphine. Both of those are correct. Nikki, you get 2 points. Remember, it is okay for you not to know the answer to any of the questions that I ask. Make a note of it, however, today after the session or tomorrow, that you go back and review it. That'll help you with your recall. Very, very good. Couple more are going to be cocaine and oxycodone. But there is many more, and so please go and review the high yield for Schedule 2. For older patients, or patients who are on multiple meds, or patients that are compromised liver function, we recommend LOT, L-O-T. That's going to be lorazepam with a brand name of Ativan, oxazepam, and temazepam with a brand name of Restoril. Does anyone know the brand name for oxazepam? I'll give you a hint. It starts with the letter S as in Sam. LOT, they are less likely to accumulate and cause toxicity. Other uses, we're going to use these for pre-medication for anesthesia, status epilepticus, alcohol withdrawal, panic, and seizure disorder. And I will put those in, we'll discuss those in a later slide. Very good. Tara, Vicky, correct. Tara, I saw the autocorrect. That can be a pain sometimes. Next, we have limitations. Drowsiness, impaired driving, memory impairment, and anterior-grade amnesia. So anterior-grade amnesia is going to be from when you take the dose going forward. Retrograde will be backwards. Tolerance, rebound anxiety, or withdrawal symptoms may occur following abrupt discontinuation or a large increase in dose. So, tolerance, you see it in alcohol, you see it in other medications. Rebound is going to be if you stop or you change the dosage, the anxiety can return worse. Drug abuse and addiction is common with benzos, not just for the treatment of anxiety. Caution with a history of drug abuse or alcoholism. There is a boxed warning, and I'll bold it for future reference, but it can be lethal if combined with opioids, alcohol, or other CNS depressants. This can result in respiratory depression and death. These are pregnancy category D, which means it has to be a life or death situation, and benzos have to show more benefit or harm than harm. So I added the special populations. We have LOT, and this is metabolized mainly via conjugation and cleared primarily by the kidneys. And LOT drugs have decreased P450 interactions. Chronic anxiety, SSRIs or SNRIs are first-line medications. In the chat, if you know an SSRI or SNRI, you can use the generic or brand name. Please go ahead and put those in the chat. Once again, the question is SSRI or SNRI, generic or brand name is acceptable. Beta blockers, propranolol and atenolol, are used to treat somatic symptoms, and this is for palpitation or shakiness that is associated with anxiety. Give everyone a chance to answer. I know you know at least the name, and don't be shy. Spellings, pronunciations are all accepted. Next, we have non-benzo options, and that's going to be busbarone or buspirone, or if you're Italian, buspirone. Mechanism of action, the true mechanism of action is unknown. It has no affinity for the benzodiazepine receptors and no effect on GABA. It does have an affinity for serotonin receptors and moderate affinity for D2 dopamine receptors. The dose is going to be 7.5 mg BID, which is our starting dose, and max is going to be 60 mg per day, with or without food. However, you must be consistent in that choice. Are you taking it with your meal, or are you taking it before or after your meal? Lexapro, sertraline, venlafaxine, and Prozac are all acceptable. Great job, those of you that answered. Next, we have knowing that this is a major CYP3A4 substrate, we want to avoid with grapefruit juice. Do not, under any circumstances, give with MAO-Is. MAO-Is are going to be monoamine oxidase inhibitors. Now, this medication takes 2 to 4 weeks to work and has a slower onset than benzodiazepine. Side effects are going to be dizziness, drowsiness, headache, and nervousness. All right, some general notes. For chlordiazepoxide, it's also used for alcohol withdrawal. Clonazepam can be used for seizures. Diazepam is used for status epilepticus and alcohol withdrawal. Temazepam can be used for insomnia, and the brand name for that is Restoril. So sleeping is when we're resting. Should help you to recall that. Alprazolam we have to use with caution due to many inhibitors and many inducers. Oxazepam is used in alcohol withdrawal. Some key counseling points here. Buspirone or buspirone tablets are scored to break in half or 1/3, can cause dizziness, drowsiness. Benzos, if you use them greater than 10 days, taper them off. Do not stop suddenly. The withdrawal symptoms can be pretty intense. Anxiety, shakiness, tachycardia, insomnia, and muscle pain or muscle spasms. The short-acting benzos are highly addictive and they can cause drowsiness. Do not mix with opioids or alcohol. If you mix with opioids, can cause profound sedation, which can result in death. And with alcohol, you have an increased risk of CNS depression. Now, I have, if I recall, 4 practice questions. And next week, we'll probably do depression. That's a pretty meaty topic. And next week, we'll probably do 4 longer sessions in the sense that they'll take 45 minutes to an hour to do. So, if you're new, I'll read the question and when I'm done reading, please put your answer in the chat. If you're not sure, you can put a question mark by it, and then we'll know it's a guess, and make sure that you review it later. So the first question is going to be, which of the following is not an advantage of using Buspar over a benzodiazepine to treat anxiety? So first, answer choice A, Buspar works relatively quickly. Choice B, Buspar has a lower risk of abuse or addiction. C, Buspar is better tolerated in the elderly. And D, Buspar is not a controlled substance. Okay. Give everyone a chance to answer. Once again, which of the following is not an advantage? All right. So the correct answer for this one is going to be A. Buspar does not work relatively quickly. It can be 2 to 4 weeks for an onset as well as starting to feel a difference. Choice B and C are correct. All right, very good. Correct as written, as is choice D. Does anyone have any questions or concerns for this practice question 1? All right, we'll go on to the next one. This one is a little longer and it is select all that apply. One may be correct, all of them may be correct, or somewhere in between. Both RxPrep and the past Naplex now QBanks do a great job not setting a pattern, excuse me, in select all that apply. When you take the pre-Naplex, any other assessment, or the actual Naplex, there is no pattern to select all that apply. So you may get several in a row where all of them are correct, one of them are correct. So it's important to know what your information. So AA is a 66-year-old female patient that is being seen in the family medicine clinic for treatment for her depression. Patient reports feeling tired all the time, lacking motivation, inability to focus, and her relationship with her husband and friends has become strained. 10 years ago, she was diagnosed with depression, and her physician at the time put her on Zoloft, but she quit taking it after feeling better. The patient reports this has been ongoing for 6 months despite trying to counter with St. John's wort. The patient was diagnosed with epilepsy 2 years ago and has HER2 positive, HR positive breast cancer. Past medical history is going to be depression, epilepsy, and the breast cancer. Current medications are going to be Lamictal PO, tamoxifen, and St. John's wort supplement. Uh, Her provider wanted to run some potential pharmacotherapy options by you. Which of the following are true regarding selection of an antidepressant for AA? Select all that apply. Choice A. Wellbutrin may lower the patient's seizure threshold and will be contraindicated considering her history of epilepsy. Choice B. Prozac and paroxetine may increase tamoxifen concentrations via inhibition of CYP3A4. Choice C. Mirtazapine would be a potentially good option for this patient if she is seeking weight loss. Choice D. St. John's wort is not considered first line to treat the patient's depression and is a CYP3A4 inducer. Choice E. Paxil has significant anticholinergic side effects and should be avoided in the elderly. While you are thinking and typing in your answers, this is an area 2 and area 3 question. So area 2 is going to be pharmacology. Drug characteristics. And area 3 is going to be develop or managing treatment plans. Sorry, I blanked on that area 3. Getting some answers coming in. Good job if you put the question mark. It's good to be honest with yourself. In the resources section of the Discord, there is a link for the top 300 and top 200 brand names and generics. It's very important for you to know this. Do some every day. It's a lot to take in all at once. We'll wait one more minute for one more response. Okay, very good. So the correct answers here are going to be A, D, and E. Okay, now we're going to start with choice E. Paxil, it has strong anticholinergic effects. The generic for Paxil is going to be paroxetine. And um, Bobon21 is correct. It is on the Beers list, and it has side effects which are highly anticholinergic, sedating, and can cause orthostatic hypotension. The Beers list is quite extensive. You definitely should know some of the high yield. Now let's look at choice D. D is also correct because it is correct as written. CYP3A4 inducer and not considered first line. It can decrease concentration of many drugs, including protease inhibitors, which are used in the management of HIV. Now, choice C. Choice C is incorrect because mirtazapine does not help with weight loss. It stimulates appetite and can cause weight gain. So, if patients have been depressed and have lost weight due to eating less, mirtazapine is a great option for the treatment of depression and weight gain. Now, choice B is incorrect. Choice B do not inhibit CYP3A4. They're actually 2D6 inhibitors. Okay? So, it was tricky here. The question has an inhibitor but the wrong CYP. So, tamoxifen is a prodrug. It requires 2D6 metabolism to be converted to an active metabolite. So, uh, be careful if there is a 2D6 inhibitor or inducer along with tamoxifen. So, the last one, choice A, is correct as written. Bupropion or Wellbutrin is contraindicated in patients with seizure disorders. This is listed on the package insert. It can cause up to a fourfold increase in the incidence of seizures and is not recommended in patients with that medical history. So, once again, choice A, choice D, and choice E are correct. Does anyone have any questions or concerns about practice question 2? Okay, let's continue to question 3. A 25-year-old male with past medical history significant for generalized anxiety disorder, schizophrenia, GERD, and insomnia presents to the ED after being found by his parents with concerning symptoms. He currently takes zolpidem 10 milligrams at night, aripiprazole 30 milligrams daily, omeprazole 20 milligrams at night, buspirone 15 milligrams BID, and acetaminophen 1 gram TID is needed. Vitals are 103.5, temp, respiratory rate of 22, BP of 178 over 100, with significant variability among the readings. Heart rate is 130 beats per minute. He has significant perspiration and sweating and significant lead pipe muscle rigidity. Which of the following syndromes or diseases is most likely? The wording is not clear, but there is only one choice. All right. Anyone else like to try? While you're waiting, if you've taken the Naplex before and have your score report, you're welcome to share it with me in direct message. I'd be happy to provide you with feedback. Or if you've taken an assessment and you'd like to share that with me, I'd be happy to provide you feedback. So, the correct answer here is going to be D as in dog. Aripiprazole is a neuroleptic often used in the management of schizophrenia. These symptoms, there's a lot of overlap between choice A and D. However, anytime there is muscle rigidity or the buzzword is going to be lead pipe, that's going to be NMS or neuroleptic malignant syndrome. Uh, Choice C can happen with atypical antipsychotics. However, tardive dyskinesia is characterized by involuntary movements of the jaw, lips, and tongue. Now, serotonin uh, syndrome, you would need serotonergic agents, and so that is not present here. Malignant hyperthermia we'll see with usually anesthesia or depolarizing neuromuscular blockers. So, if you chose D, great job. This is like an anxiety adjunct question, and as you know, there's no pattern on the Naplex as well. Any questions or concerns about practice question 3? Remember, if you think of one later, you're welcome to reach out. All right, let's continue with practice question 4. Which of the following correctly matches the drug with its antidote or reversal agent? Select all that apply. Choice A, warfarin, phytonadione. B, dabigatran and andexanet alpha. Choice C, diazepam and flumazenil. Choice D, fentanyl and naloxone. And choice E, organophosphates and physostigmine. Right. Okay. So the correct answers here are going to be A, C, and D. All right, this is a little tricky, and let's talk about why. A is correct as written. Phytonadione, or however you'd like to pronounce that, is vitamin K. And as warfarin is a vitamin K antagonist, vitamin K would be your antidote. Normally, it's given when INR is greater than 10 or significant bleeding is present. When it's given IV, always administer it slow infusion to minimize the risk of anaphylaxis. Choice B is incorrect because the reversal agent for dabigatran is idarucizumab. Now, the brand name for dabigatran is Pradaxa, and the brand name for the antidote is Praxbind. Okay? Praxbind is a monoclonal antibody fragment, and it binds to dabigatran and its metabolites. Now, this one that's listed, andexanet alpha, is approved for apixaban and rivaroxaban, both of which are factor 10A inhibitors. Okay, so once again, dabigatran is going to be idarucizumab, and the andexanet alpha is for apixaban and rivaroxaban. Answer choice C is correct as written. Good job if you chose that. And answer D is correct as written. So flumazenil competitively inhibits the activity at the benzodiazepine receptor side on the GABA benzodiazepine receptor complex. So flumazenil does have an increased risk of seizures, so practice caution. D, naloxone. Uh, it's an opioid antagonist. It displaces opioids at the receptor sites. It has a very short half-life and may be administered in repeat doses or as a continuous IV infusion, especially in cases of overdose with either long half-life opioids or extended duration of activity. So, methadone has a long half-life, or fentanyl patches or sustained release morphine formulations. Okay. Answer choice E is incorrect because the antidote for organophosphate poisoning is going to be atropine and pralidoxime. Once again, atropine and pralidoxime. Physostigmine is used as an antidote in anticholinergic toxicity, which could be caused by atropine, scopolamine, benztropine, and belladonna poisoning. Okay. All right. Does anyone have any questions or concerns about practice question 4, the presentation for today, or in general? If you're new, remember there's a survey. Please fill that out and provide your feedback so we can improve these sessions. You're welcome. All right. If you think of a question later, let me know.